Hi everyone, this is Neil Writer, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have 3 different cases in this compilation video, and this is of patient 1. 2 of the 3 cases involve an abnormal eardrum, and as we go through this procedure, I'll explain the abnormality and why that abnormality occurs. So this patient is a regular patient. They tend, I think, twice a year to have dead keratin, so dead skin removed, as opposed to earwax. And this skin fails to fully migrate out of the ear, primarily because they've got a retraction. Their eardrum is sucked and pulled inwards, quite severely in this case. And so I'm just using microsuction to peel away this dead skin. They did use a cotton bud, so you may see a few woolly strands there. And they're no better, but it was causing a bit of itchiness for them. And they did apologise. I've been seeing this patient for, I think, 8 years now. And it's one of my actually first patients I performed microsuction in back in 2015. So things have changed quite a lot since then. And so this patient's eardrum is abnormal in 3 ways, I would say. You can see the anterior part of the eardrum is calcified. It's we call that tympanosclerosis. Tympanosclerosis is an umbrella term, really, for a calcification of the eardrum, so you get a buildup of calcium salts. But I'll come back to that in a moment. So where those arrows are is where the eardrum is sucked inwards, it pulled in, and I will explain that in more depth during the course of the video. So the white chalky patches appearance on the front section, so the front hemisphere of the eardrum, is tympanosclerosis, and it's a buildup of calcium salts, and it's normally secondary to infection. It can also sometimes be an autoimmune response, and also the insertion of grommets, which are ventilation tubes, which again I will try and talk about that later on this video as well. Can all then lead to tympanosclerosis. So tympanosclerosis, this scar tissue and this plaques is also affecting the ossicles, the 3 bones that are connected to the eardrum. We call that intratympanic tympanosclerosis. But if it's just the eardrum itself, it's called meringosclerosis. Now, the second abnormality out of 3 for this patient's ear is that their middle bone, the anvil, also known as the incus, is eroded. And you can see the hammer bone in the centre of the eardrum. And then to the left, you're going to have another view in a moment, you'll see this round spherical shaped bone. That's the head of the stapes. So that's the 3rd bone, also known as a stirrup, and that's the head section. And there should be an intermediate bone between the 2 that's missing, and that's because it's eroded. So patient 1's successfully treated. This is patient 2. Patient 2 has a normal eardrum, so I'm sandwiching in the normal eardrum in between the 2 abnormal ones. So why is this patient's eardrum pulled inwards? Now, the eardrum is a barrier, if you like. It separates the middle ear cavity, which is the space directly behind the eardrum where you've got the eardrum itself, the 3 bones, the ossicles, and the eustachian tube, which connects to the back of the nose, and I'll come back to that. And it separates that from the outer world, so the ear canal and the outer atmosphere. And ideally, we want the air pressure behind the eardrum to be equal to the air pressure in the atmosphere. And when the air pressure is equal either side of the eardrum, that's when we hear the best. That's when the eardrum is most mobile. So what regulates the air pressure in the middle ear is the eustachian tube. So it's a narrow orifice connecting the middle ear to the back of the nose, the nasopharynx. And at normal resting state, the eustachian tube is closed at the back of the nose. So the eustachian tube at the back of the nose is made up of cartilage, and where it is in the middle ear, it's made up of bone. And during brief moments during the course of the day, if you're yawning, swallowing or chewing, muscles contract in the nasopharynx where the eustachian tube is, and it causes the eustachian tube to momentarily open, allowing the air pressure to equalise. So if there's too much air, some air will escape, and if there's not enough air in the middle ear, so if it's negative pressure behind your eardrum, you'll have air enter. An example of your eustachian tube working but forcefully by yourselves, so you're taking control of it, is when you're descending on an aircraft. If you have quite a sudden descent, and you're coming down on the aircraft, the cabin air pressure is greater due to that downwards g-force than the air pressure behind your eardrum. So your eardrum, which is like a piece of cling film, if you like, gets pushed inwards. And then we can experience reduced hearing, pain or fullness in the ear. And one of the techniques often used to equalize the air pressure is called the Valsalva maneuver. And that's when you close your mouth, pinch your nostrils shut, and then you blow into your nose, trapping that air inside your nose. And that air, because it can't escape out of the nose, it travels upwards and it forcefully opens up the eustachian tube and it allows air to enter, and then it pops your eardrum back out. So it basically re-equalizes the middle ear pressure. So that's the function of the eustachian tube. Now, for many reasons, the eustachian tube can fail to open when it should normally open. And so that could be due to infection in the nose. It could be due to a cancerous tumour, even a malignant tumour in the back of the nasopharynx. It could be due to deviated septum, sinusitis, rhinitis, enlarged turbinates. The muscles can become paralysed or weak. Just could be congestion, inflammation following a cold. So there is multiple reasons, or it could just be the eustachian tube is inherently really, really narrow and it doesn't really open much at all. It should. So when the eustachian tube fails to open, we call that eustachian tube dysfunction. So again, it's an umbrella term to encompass many conditions that may cause the eustachian tube not to open. And I'll come back to that in a moment. So this here, just a soft plug of wax. Just use some medical grade olive oil and just to bind it together and loosen up the canal walls. And you can see we've managed to remove that. They've got quite a bendy ear canal. So this is the second bend where I am now. And anything beyond that is the bony part of the ear canal. And then you'll see this eardrum in a moment. It's nice and healthy. So when the eustachian tube is dysfunctional, it means that air can't enter the middle ear, and all the remaining air that once was in the middle ear, that gets absorbed by all the cells that line the middle ear, so all the mucosal cells. And when all the cells in the middle ear absorb, so through gaseous exchange, it then causes fluid, intracellular fluid from these cells to be forced out, and that then enters the middle ear. And this fluid, intracellular fluid, can then get infected and it can't drain out of the eustachian tube. So the fluid builds up and it can then lead to secondary glue ear or otitis media with effusion. So the eustachian tube is not only to help equalise the air pressure, but it prevents the buildup of intracellular fluid through the equalisation of the air pressure in the middle ear. Now, when there's no air in the middle ear, and that therefore creates negative middle ear pressure, so the air pressure behind the eardrum is below that of the atmospheric air pressure, so that's negative middle ear pressure, it sucks the eardrum inwards. And it normally sucks the eardrum in, I would say posteriorly, like you saw in patient 1, and you're going to see quite severely in a moment in patient 3, but also in the attic. So this is patient 3, and you can already see the posterior, the right-hand side of the eardrum severely sucked in. So when the eardrum is sucked inwards, it's typically in the attic region. That's because the top part of the eardrum, the attic, also known as the pars flaccida, is thinner. It contains the 3 layers of the eardrum, so the epidermis outer layer, the mucosal skin inside layer, and also the fibrous middle layer. But the fibrous tissue is more diffuse, whereas in the pars tensa, the main body of the eardrum, the middle layer, the pars tensa, the fibrous layer, is more concentrated, and you get the linking of these different fibrous tissues. It's not as diffuse, so it gives the eardrum more strength and rigidity. But also in the back region, it can get sucked in there. So the eardrum there can get sucked in to a part of the middle ear called the antral region of the mastoid. So behind the ear, we have the mastoid bone, which it's air-filled. It looks like a honeycomb structure. And you can actually access that via the middle ear. So if you go through the eardrum and turn sharply right in the case of this patient's left ear, where the eardrum sucked in, and then do another right turn, that's the entrance to the mastoid bone. So quite often the eardrum can get pulled into the attic or antral regions of the middle ear. And when it gets pulled in, it can cause symptoms of reduced hearing, of fullness in the ear, occlusion, so when you're eating or chewing, that sound gets amplified inside your head. Autophony, that's when you can hear your own voice inside your head. It can sometimes cause vertigo. It can cause most ear symptoms, if truth be told. And in addition, if the eardrum is severely sucked in, it can wrap itself around some of the bones in the middle ear and almost strangle it. It strangles all the blood vessels, capillaries, feeding and nourishing and providing oxygen to the bone. And it strangles those blood vessels, so the bone is starved of all the necessary oxygen nutrients that it requires, and that bone can then start die away, so we can get sickle necrosis. Obviously, if there's then a fluid buildup as well, and that fluid gets infected, that too can also cause necrosis of the bones. So patient 1 and patient 3 have got eustachian tube dysfunction. It's long-standing, and in both sides, they don't actually have buildup of wax. It's dead skin, keratin here. And I have noticed that with a lot of patients who have got severely retracted eardrums, the skin, the migration of skin is a lot more difficult, or a much slower rate, which then causes a build-up. Now remember, this skin that's migrating out of the ear, it all stems from the eardrums, from the centre, the umbo. So as I said, the outer layer of the eardrum is also made up of the same skin that lines the ear canal, and it's the epidermis layer. And as that skin dies and replaces itself, the old skin then starts shedding and migrating sideways from the centre of the eardrum. And you can always compare it to a pond or a puddle, and you drop a pebble in the centre and you get those ripple effects. Imagine those ripples being the dead skin. So from the centre of the eardrum, it migrates radially outwards, and then it goes onto the ear canal wall, and then slowly but surely out of the ear. And that rate of migration does vary. It's between 1.5 millimetres and 3 millimetres a month. It's similar to the fingernail growth. So there is individual differences. Now, this patient here has also got quite a narrowing. You can see at the base of the ear canal near the eardrum is quite a V section here. You can see some granulation tissue on the right-hand side of the posterior canal wall. So this is quite a difficult one to remove, because the patient was experiencing mortalgia in here. So be really, really gentle. And the skin, it wasn't dry and crumbly and short, almost like patient 1. When I mean short, it's like with short bread biscuits, they're very crumbly. So patient 1, I would say their dead skin was very short, because it just crumbled away and flaked away. Here, the skin has almost become macerated, so it becomes sticky, and I suspect there's probably some fungal involvement here. So with dead keratin like this, and it's a bit sticky and gooey, there may be some fungal involvements of some candida or even some aspergillus. So I'm just gently peeling away this, and it is tricky. And now there is going to be some leftover. Guys, yeah, I've had a couple more emails about me not apparently finishing procedures, and some comments as well. So, okay, I'm just not very good at what I do. I hope that satisfies those viewers and commentators. To those who understand a bit more about the complexity of what we're doing, it is really, really tricky to remove everything, and primarily because this patient's awake, we're right up against the canal wall. I know on the screen it looks huge, it looks really, really massive, but we're working within inside a space of below a centimetre in diameter, and quite often much, much less than that. And we're using sharp penetrable instruments that could do some serious harm to the patient. And I say the diameter could be less than a centimetre. That's at the widest part of the ear canal. The ear canal varies in width and height across the different sections of the ear canal. So, for example, between the first and second bends of the outer third of the ear canal, that's when the ear canal is at its most narrowest, and at that region it could be anything like between 0.4 to 0, in width, centimeters to 0.6 centimeters in height. At the eardrum itself, the diameter and is at its greatest, so it is normally at the entrance. So, and the ear canal also, it's not straight, it's bendy, so it's not a straight cylindrical tube. We have to then navigate around those bends. So it's a very small area that we're working in. And when you've got consistency of dead skin like this, it's very difficult to peel away. So you can see this patient's eardrum, and I will freeze it. They've got an attic retraction as well, and also a posterior retraction, which is going inwards towards the antral region of the mastoid bone. Just peeling away as much as I can. You can see, you know, it's almost like they've got a bit of exotosis, so some bony spurs, sometimes also called surface ear. Will I have enough time to talk about that? Probably not. So, in terms of treatment for eustachian tube, if it's to do with you mainly treat that via the back of the nose. So, for example, if a patient's got a nasal polyp causing obstruction, then you'll see an ENT to have that removed. If you've got rhinitis or sinusitis, there's medication, endoscopic sinus surgery, a deviated septum, again, you can have a septoplasty. If there's congestion, mucus, and nasal decongestions. Sometimes it could be bacterial or viral infections, so appropriate antivirals, antibacterials. Other means are if it's a chronic issue and it's not resolving itself and it's really causing symptoms, then you can have a grommet or a T-tube or a ventilation tube. It's got different names. And essentially, it's when an ENT surgeon pierces the eardrum, creates an artificial perforation, and to prevent that perforation from healing, because typically it will self-heal between 6 to 12 weeks, a grommet is inserted. So it's like a rubber silicone hollow tube where it goes through the eardrum and it's locked in place, and it just stops the eardrum from self-healing, and the artificial hole created through the eardrum is a bypass for the eustachian tube. So because air can't enter the middle ear via the eustachian tube, the hole in the eardrum allows the air to enter via the ear canal. So it equalizes the air pressure either side of the eardrum via the ventilation tube, and then hopefully that will also prevent intracellular fluid from being drawn out from the middle ear cells. So we're right here on the scutum. This is the top part of the bone near the eardrum, and I'm peeling the skin away, but I just stopped actually. So I think the patient was getting it, from memory serves me correct, they were getting a bit dizzy at this stage because of the caloric effect, and I just wanted to make sure the skin wasn't growing upwards into that retraction pocket. But we've referred this patient onto ENT already. They are overdue an appointment. They were normally being seen on a regular basis, but because of all the backlog, unfortunately, it's been a long time. So, but there's no discharge there from what I can see, so that's a good sign. So that's that retraction. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.